All right. So a few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For the UR board member, reserve questions until the end of presentations or ask in the Google Meet chat. For public comment, if you like to provide public comment, a COI must be on file. Please send an email to medicaiepharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaiepharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meetings to help us improve our process moving forward. Thank you. With that, I leave it to Dr. Cannon.
All right. If we've got a quorum, then we'll call this meeting to order. Good morning, everyone. Thanks for taking the time to be here with us this morning. In terms of minutes, everybody should have received a copy of the minutes. Does anyone on the committee have any questions about the minutes from the last meeting? Seeing head shakes, I'm going to take that as no. Can I get a motion to approve the minutes?
So moved.
Thanks, Catherine. Have a second?
Second. Sorry.
We'll give that one both to Dr. Weinstein and Siegfried. All in favor of approving the minutes, say aye.
Aye.
Any opposed? All right. The minutes are approved. Noon, I will turn it over to you.
Thanks, Eric. So there's a few housekeeping items for this morning. The first is, Eric, would you like to say your farewell to the board?
Yeah, after a long time of participating with the board, I've had a lot of changes at work and have had to make the hard decision that I will no longer be participating on the state's DUR board. It's been an amazing opportunity for me to get to know all of you and participate with you, and have been touched by the people on the committee and even some that are no longer on the committee or no longer here. It's had a tremendous impact on me in my life. So just a big thank you to all of you. I feel enriched having been able to interact with all of you. So thank you. And with that, Noon, I'm going to turn it over to you to get rid of me and find somebody else.
Thank you, Eric. It was my pleasure working with you throughout all the year, and we are thankful for your contributions to the DUR board. In the replacement of Dr. Cannon will be Dr. Laura Britton from the Healthy U ACO. With that, I will also take on the nomination and election of the board chair. If anyone want to propose the nominations or want to take on the role of Dr. Cannon as the chair for the DUR board. Any nomination? Dr. Brinton?
I would like to nominate Dr. Weinstein if she is willing. I don't want to put anyone on the spot, but we've had such great leadership in the team, and it's wonderful to have so many wonderful options.
I heard Dr. Weinstein. Is that your nomination, Dr. Brinton?
Yes.
Yes, I wasn't expecting that, but thank you. I would have to just consider, what obligations, there are besides the monthly meeting. That's I think this is a really important task and an important committee, and would want to, be fully available and present. And I'm not sure. I'm not sure that I can do that, not understanding all what goes on in between meetings. I was thinking to nominate Catherine Smith. I don't know if she's available.
I politely decline, but thank you for nominating me.
I can explain a little bit about the role Dr. Cannon has been doing a wonderful job of is conducting the meetings when the chair is present, and also connecting the board members, making sure that there's a motion made, making sure that there is a second made, be clear during the conducting of the meetings, be prepared for the meetings. Dr. Cannon, would you like to say something about the role that you have been taking on so the board can have a better understanding of the role so they can take the nominations?
Yeah, I think Dr. Weinstein, there's some coordination back and forth via email. Compared to everything else in my life, this is a pretty easy lift. And so, I think in terms of what, I've done is just make sure that I'm prepared. And so, I mean, it's just taking the time to make sure I've read through everything, know what the discussion's going to be about, and showing up in the morning. So I'm usually late to meetings. I've gotten to be pretty good with this one. So maybe I've turned a corner. I haven't. It hasn't been a burden. I'll just say that.
Okay. Is there an option for anybody who's present on the committee today who would like to serve and would nominate themselves if that's an option?
Yes, if anyone would like to nominate themselves to be the chair, that would be great too.
If we have no other volunteers, I would respectfully accept and hope that over the next 6 months or so, we might broaden our membership and encourage other people to come forward to take a leadership position.
Thank you, Dr. Weinstein.
And I know, I'll just be honest with this group. COVID hitting and these meetings becoming virtual. And I was sitting at dinner last night with my wife in a restaurant and just telling her, but I mean, Kumar and I developed a friendship simply because he and I would sit together when we were on site, and without having that on site, I feel bad because I haven't developed the relationships with some on the committee that I have with others. And, it's due to that opportunity to be more interactive. And so, knowing that that's something you all may want to consider, because I think the interrelationships between those on the committee and knowing more about each other and when to ask questions of someone is really important. And you can't do that in Google Meets. But I also understand the realities of today's world. So just a thought.
We appreciate your feedback, Dr. Cannon. Yeah, I think the team had talked about moving the meeting to in-person, but it's still to be decided. for the upper leaderships upon that as well. We worry about the attendance coming into in-person meeting.
Just schedule really controversial stuff, like one item every meeting. You'll have people there.
Yes. With that, thank you, Dr. Weinstein, for accepting the chair's position for the DUR board. So moving on to the next item as well. Brian, would you like to say something to the board as well?
I will, but before I do, I think the nomination needs to be voted on. So I'll defer to that action first.
Oh, thanks, Brian. Do we have a motions for Dr. Winston to be the board, to be the chair?
So move.
Thank you, Dr. Brinton. Do we have a second?
Second.
I'm sorry, can I have a second one more time? Sorry, I missed that.
Second. This is Catherine.
Oh, thank you, Dr. Smith. All right, motion move for Dr. Weinstein. And back to you, Brian.
Yes.
Everybody in favor, say aye.
Aye.
Any opposed? Perfect. Vote carries.
Thank you, Dr. Cannon, and thank you, Noon. So I wanted to let the DUR board know that I have accepted a position with PEHP and will be leaving Utah Medicaid. And I'd like to echo Dr. Cannon's words and express my appreciation to the DUR board and the P&T committee. And it's been an amazing opportunity for personal and professional growth for me, and getting to know people on the DUR board and the P&T committee, as well as those at the DRRC and of course my colleagues at Utah Medicaid. I'm going to miss everybody, and I really feel enriched for having spent the time I have with Utah Medicaid, and yeah, thanks for letting me be a part of all this.
All right. Thank you, Brian. We appreciate that. And you will also be missed. I think it's, probably a great opportunity for you. I know there's some changes happening there at PEHP, and so we're excited for you to have that opportunity. It's also been a pleasure to work with you. So moving on, we're going to talk about CAR-T therapies today. So I am not quite certain who's going to be presenting from the University of Utah, but we will turn that over to them.
Sure, that's going to be me today. Hopefully everyone can see the slides. Please let me know if not. So good morning. Today, the presentation will review considerations for the use of FDA-approved chimeric antigen T-cell therapies, abbreviated CAR-T, for relapsed or refractory multiple myeloma, including ciltacabtagene autoleucel and idacabtagene vicleucel, that I'll refer to as cilta-cel and ida-cel, respectively. So multiple myeloma, abbreviated MM, is a blood cancer of antibody-producing B cells, known as plasma cells, that occurs within the bone marrow and or at other localized sites. MM accounts for about 1 to 2% of all cancers and 10% of blood cancers diagnosed annually in the US. It typically affects older adults with a median age of 69 years at diagnosis. Usually, MM is incurable, with a disease course characterized by periods of remission followed by multiple relapses and refractoriness despite the most advanced treatments. First-line therapy for MM usually includes a 2 to 4 drug chemoimmunotherapy regimen containing medications from the drug classes of proteasome inhibitors, immunomodulators, and/or anti-CD38 monoclonal antibodies, possibly followed by an autologous hematopoietic cell transplant and maintenance chemotherapy. While these therapies prolong survival, historically, survival is poor among patients who are treatment refractory or with multiple relapses. For example, the median duration of progression-free survival was 4.6 months, and overall survival was 12.4 months in a recent prospective cohort of patients relapsed or refractory who received standard of care non-CAR T therapies after treatment with at least 3 prior lines of therapy. So there are currently 7 FDA-approved CAR T products with different immunotargets that are used to treat various types of cancer, and many additional products are in clinical development. Cilta-cel and ide-cel are the 2 FDA-approved CAR T therapies for MM. CAR T therapies are cell-based immunotherapies produced by genetically modifying the patient's own T cells to express a particular receptor that targets an antigen on cancer cells. Both cilta-cel and ide-cel target the B-cell maturation antigen, abbreviated BCMA. BCMA is a favorable treatment target in MM since it is primarily expressed by plasma cells. After a one-time intravenous infusion of cilta-cel or ide-cel, the genetically modified T cells proliferate upon encountering cells expressing BCMA, and they destroy these cells by direct and indirect cytolytic mechanisms. Cilta-cel and ide-cel utilize different antigen recognition domains on their chimeric antigen receptors. Cilta-cel can recognize 2 different antigen binding areas compared to 1 for ide-cel. While both are indicated for adults with relapsed or refractory multiple myeloma, abbreviated RRMM, cilta-cel is approved for RRMM that is refractory to lenalidomide after 1 or more prior lines of therapy that included immunomodulator and proteasome inhibitor, whereas ide-cel is approved for RRMM after 2 or more prior lines of therapy that included an immunomodulator, proteasome inhibitor, and an anti-CD38 monoclonal antibody. Thus, cilta-cel can potentially be used as an earlier line of therapy than ide-cel. Notably, these indications reflect the recently expanded FDA-approved use as of April 2024. They were initially approved for use after 4 or more lines of therapy until more evidence for their use as earlier lines of therapy became available. Both cilta-cel and ide-cel are administered as a one-time intravenous infusion over about 30 to 60 minutes, using either a weight-based dose as with cilta-cel or a non-weight-based dose range as with ide-cel. The procedures for preparation and administration of these therapies are medically intensive and require multiple steps over weeks to months. First, leukapheresis must be performed to collect white blood cells, which are sent to the CAR T product's manufacturing site. Depending on the patient's disease status, the patient may receive bridging chemoimmunotherapy to maintain sufficient disease control while they wait for their CAR T therapy to be manufactured. The manufacturing process typically takes 4 to 5 weeks. Approximately 5 to 7 days before cilta-cel or ide-cel administration, patients must receive a 3-day lymphodepletion chemotherapy course. This procedure is intended to make space for CAR T expansion and persistence once infused, thereby boosting efficacy. Ide-cel and cilta-cel's prescribing information recommend lymphodepletion with IV fludarabine and cyclophosphamide with dose adjustment for renal impairment. Pre-medication with an antipyretic and antihistamine should be given 30 to 60 minutes before the ide-cel or cilta-cel infusion, while systemic corticosteroids should be avoided because they may hamper efficacy. Because of the risk of cytokine release syndrome and/or neurologic toxicity, both cilta-cel and ide-cel must be administered at a REMS program certified facility, which requires the healthcare facility to attest to having available emergency resuscitative equipment and at least 2 doses of tocilizumab per CAR T treated patient. Post-infusion monitoring is also required due to the risk of delayed toxicity. Daily monitoring, likely as an inpatient, is required for at least 7 days following the ide-cel infusion and at least 10 days following the cilta-cel infusion. Additional frequent monitoring at the certified healthcare facility, possibly as an outpatient procedure, is required for at least 4 weeks after the ide-cel and cilta-cel infusion. This means that the patients must remain within a reasonable proximity of the treatment facility for at least 1 month after the infusion. Patients are recommended to not drive per prescribing information for at least 8 weeks after an ide-cel or cilta-cel infusion. So to summarize the place in therapy for ide-cel and cilta-cel for we reviewed various guidelines or expert opinion references. The primary guideline used was the Multiple Myeloma Treatment Guideline from the National Comprehensive Cancer Network, abbreviated NCCN, that was last updated in September 2024. For safety information about CAR-T products, we also reviewed the NCCN guideline on the management of immunologic toxicities. While diagram treatment algorithms were updated in the NCCN guideline, the guidelines discussion section that typically elaborates on those recommendations had not yet been updated to reflect the expanded FDA indications. So we also consulted the International Myeloma Working Group, or IMWG, CAR-T guideline for and some recent expert opinion publications. The NCCN recommends ide-cel or cilta-cel among preferred treatment options for RRMM in 2 contexts with different levels of evidence and consensus. First, as a Category 1 recommendation, which is based on the highest level of evidence and high consensus, cilta-cel is a preferred option after 1 to 3 prior lines of therapy that included an immunomodulator and protease inhibitor, and that is refractory to lenalidomide, and ide-cel is a preferred option after 2 to 3 prior lines of therapy that included immunomodulator, anti-CD38 antibody, and proteasome inhibitor. As a Category 2A recommendation, which is based on a lower level of evidence with high consensus, both ide-cel and cilta-cel are recommended by the NCCN for RRMM after 3 lines of therapy without requiring specific prior treatments. Yet after 3 lines of therapy, it's likely that patients would have received the commonly used medication classes per the indication. For a given line of therapy at which cilta-cel or ide-cel are NCCN preferred options, there are also other NCCN recommended options with a similar levels of evidence and consensus. Other NCCN preferred options as Category 1 or 2A, depending on the regimen, after 1 to 3 prior lines of therapy, are 3-drug chemoimmunotherapy regimens, typically including a drug or drug class from commonly used medication classes that the patient has not previously received or that was not used in the most recent line of therapy. Autologous hematopoietic cell transplant may also be an option for patients who delayed it during initial treatment or for patients who had a prolonged response to their first transplant. For RRMM after 4 or more lines of therapy, bispecific antibodies, including some agents that target BCMA, are other NCCN preferred options as Category 2A in addition to CAR-T therapy. Notably, the NCCN guideline advises that patients may receive more than 1 BCMA-targeted therapy as later lines of therapy, potentially referring to receiving CAR-T therapy and bispecific antibodies as subsequent treatments along the patient's disease course. However, available evidence so far suggests that immediate use of a second BCMA-targeted therapy may be associated with a lower response rate. The NCCN provides limited guidance about selecting CAR-T over other equally preferred options for a given line of therapy. Generally, treatment selection depends on treatment history, patient's prior treatment response, comorbidities, and disease aggressivity or severity. We infer that CAR-T therapies might be selected based on relative efficacy, safety, and feasibility, among other considerations. And this table highlights some potential advantages of CAR-T compared to other treatment options for RRMM. An advantage of cilta-cel or ide-cel is that in their pivotal phase 3 trial, they significantly reduced disease progression and tended to result in a greater proportion of patients achieving a higher level of response compared to certain standard of care chemoimmunotherapy regimens that are among NCCN preferred options for after 1 to 3 prior lines of therapy. Another advantage of cilta-cel or ide-cel is that they are given as a one-time infusion without the need for ongoing or maintenance therapy during the time that the patient responds, unlike standard chemoimmunotherapy regimens or bispecific antibodies. In phase 3 clinical trials, the median duration of response to ide-cel was 14.8 months and was inestimable for cilta-cel after a median follow-up of 15.9 months. Nonetheless, safety or feasibility concerns may preclude the use of cilta-cel or ide-cel for some patients. Potential CAR-T toxicities, such as common adverse events of cytokine release syndrome and neurotoxicity, might discourage use of cilta-cel and ide-cel for patients who are unlikely to tolerate severe adverse events due to comorbidities or overall frailty. As severe cytokine release syndrome can manifest with hemodynamic compromise and pulmonary and cardiac dysfunction, among other symptoms, the IMWG guidelines stated that very frail patients and or those with poor cardiopulmonary fitness may not be an ideal candidate for CAR-T. Experts from the ASTCT panel advised avoiding cilta-cel in patients with pre-existing neurological disorders such as Parkinson's disease or severe neuropathy, as treatment has been associated with neurotoxicities manifesting with these symptoms. Note that cytokine release syndrome and certain types of neurotoxicity are also risks with BCMA-targeted bispecific antibodies, although the bispecific antibodies may be better tolerated by frailer patients than CAR-T therapies, according to some experts. Additionally, the requirement for the patient to remain relatively near the treatment facility for at least 4 weeks after the infusion for safety monitoring could potentially hamper treatment feasibility for some patients. In a single pivotal phase 3 randomized controlled trial, or RCT, each led to the updated FDA-approved indications. Both trials were open-label RCTs that randomized patients to RRMM to a one-time infusion of cilta-cel or ide-cel or a standard of care chemoimmunotherapy regimen that was selected from a list of options at the discretion of the treating provider. Both trials included adults 18 years of age or older with an Eastern Cooperative Oncology Group performance status of 0 or 1 at screening, indicating that patients were ambulatory and that the impact of the patient's disease status on their daily activities at most impaired their performance of physically strenuous activity. Patients were excluded if they had CNS-involved MM, Parkinson's disease, active infections, severe renal impairment, significant cardiovascular disease, or if they had received prior CAR-T or BCMA-targeted treatment, among other characteristics. The accepted prior lines of therapy and definitions of progressive or refractory disease slightly differed between the cilta-cel and ide-cel trials in ways that generally align with their FDA-approved indications, as shown in the table. Cilta-cel and ide-cel were also studied in single-arm uncontrolled trials among more heavily treatment-experienced adults with RRMM, which led to their initial FDA-approved indications as later-line therapy. The pivotal phase 3 clinical trials included patients with a median age of approximately 62 years who had received a median of 2 or 3 prior lines of therapy for the cilta-cel and ide-cel trial, respectively. Both trials achieved their primary efficacy endpoints, demonstrating significantly longer progression-free survival, defined as the time until disease progression or death, than with the standard of care regimens. In the cilta-cel trial, at a median follow-up of 15.9 months, the standard therapy arm had a median progression-free survival of 11.8 months, whereas the median had not been reached in the cilta-cel arm. In the ide-cel trial, at a median follow-up of 18.6 months, the standard therapy arm had a median progression-free survival of 4.4 months compared to 13.3 months in the ide-cel arm. A significantly higher proportion of patients in each trial achieved at least a partial response to cilta-cel or ide-cel therapy compared to the respective standard therapy groups. Additionally, when different levels of response were compared between the treatment groups in each trial, a greater proportion of patients treated with cilta-cel or ide-cel achieved the highest levels of response compared to the respective standard therapy participants. We explored information from guidelines and expert opinion review articles about administering a second dose of the same or a different CAR-T agent. We are aware of descriptive, non-controlled evidence from 6 studies that included a total of about 66 patients. Overall, these studies suggest that some patients can achieve a meaningful response to a second BCMA-targeted CAR-T product administered at the time of relapse or progressive disease. In 5 of the 6 studies, the aggregate overall response rate in the retreated patient cohorts was between 71 and 100%. However, durability of the response after the second course might be shorter than the durations observed in clinical trials after the first course, based on only a subset of these 5 studies that reported that outcome. We noted that responses occurred both among patients who were given a second dose of the same BCMA-targeted agent or a different CAR-T agent, which included at least one patient who responded to cilta-cel after ide-cel. Comparisons of outcomes between these descriptive studies and clinical trials is a bit convoluted because they are not patient-specific and could have been confounded by other factors such as the CAR-T product, disease severity, and time between the CAR-T treatments. The 6th descriptive study that was a sub-study of the KarMMa ide-cel clinical trial reported a lower response rate with retreatment than the previously mentioned studies. 21% of patients retreated with ide-cel had any response, and 5 of the 6 responders only achieved a partial response. The median duration of progression-free survival in the 28-person cohort was 1 month. However, differences in responses observed between the studies could be related to differences in timing of retreatment between studies, as the KarMMa sub-study administered ide-cel immediately at relapse after the first dose. The presence of anti-drug antibodies might also affect response to ide-cel retreatment. The 6 patients in the KarMMa trial sub-study that responded to ide-cel retreatment were negative for ide-cel anti-drug antibodies, in contrast with all 16 retreatment non-responders being anti-drug antibody positive. At least in part based on the evidence from the ide-cel trial retreatment sub-study, the IMWG guidance advises against retreatment with the same CAR-T product at the time of relapse. Yet the IMWG states that treatment with a different CAR-T product targeting a different antigen or binding domain could be considered. The NCCN guideline advises that sequential therapy with 2 BCMA-directed therapies could be considered for patients with RRMM after 3 prior lines of therapy, but the authors do not elaborate on the nature or type of the BCMA-directed therapies for subsequent use or their timing. Although neither cilta-cel or ide-cel have any labeled contraindications to use, both carry risks of serious and potentially life-threatening toxicities. In their respective phase 3 clinical trials, serious adverse events occurred among about 44% of cilta-cel-treated participants versus 39% of standard therapy participants, and 52% of ide-cel participants versus 38% in the standard therapy arm. Most CAR-T toxicities are reversible and manageable with treatment. However, there is a labeled warning regarding the increased risk of early death within the first 9 to 10 months of preparing for treatment with ide-cel or cilta-cel compared to standard therapy, which appears mostly attributable to disease progression while waiting for the CAR-T preparation and treatment emergent serious adverse events after the infusions. Ide-cel and cilta-cel carry the same labeled warnings, including a black box warnings for cytokine release syndrome, neurologic toxicities such as immune effector cell-associated neurotoxicity syndrome, or movement and neurocognitive adverse events, hemophagocytic lymphohistiocytosis or macrophage activation syndrome, new onset myeloid or T-cell malignancies, and the required REMS program. Other warnings or precautions are regarding hypersensitivity reactions, serious infections, hypogammaglobulinemia, and that patients should avoid driving or using heavy machinery for at least 8 weeks after the infusion. Key common adverse events associated with cilta-cel and ide-cel that occurred at an incidence of at least 40% and greater in absolute frequency than with the standard of care regimens in their pivotal trials included cytokine release syndrome and related symptoms, hypogammaglobulinemia, and reduced white blood cells, platelets, and hemoglobin levels. The reviewed NCCN and IMWG guidelines and prescribing information recommend various screenings prior to CAR-T therapy in general or before treatment with these agents specifically. Depending on the type of screening, they are intended to help providers identify the best candidates for CAR-T therapy in order to establish a baseline prior to CAR-T therapy. The type of or nature of these screenings vary across the reviewed sources as indicated in parentheses on the slide, but may include a cardiac, pulmonary, renal, or neurological function assessments. Also, screening for active infections as it is recommended by prescribing information to not administer cilta-cel or ide-cel to patients with an active infection or inflammatory disorder, as well as collecting baseline C-reactive protein, serum ferritin, and blood cell counts. So, given all that information, the DUR board may consider the information highlighted here to guide the development of drug-specific prior authorization for Cilta-cel or Ida-cel, along with the details that are elaborated in Section 7 of the report. We recommend requiring that patients meet the FDA-approved indication for Cilta-cel or Ida-cel based on provider attestation and/or clinical documentation. Additionally, you may consider authorizing Cilta-cel or Ida-cel for one-time use at a dose up to the FDA-approved dose and requiring that Ida-cel and Cilta-cel be prescribed by or in consultation with a hematologist and/or hematologist oncologist. If desired, additional criteria could be considered based on clinical documentation and/or provider attestations such as those listed here. To highlight a couple of the ideas mentioned here, you may consider having the prescriber attest that the patient does not have an active infection and/or that the recommended safety screenings will be performed or have been performed. Also, since the most robust evidence supports using Cilta-cel or Ida-cel as a one-time treatment and the possible benefits of administering the same CAR-T agent is not yet established, you may consider requiring that the prescriber attest that the patient has not previously received the requested CAR-T therapy. Thank you for your time and attention, and I'm happy to take any questions.
Do we have any questions from the committee? Now, why don't we move to public comment? Dr. Navis with Kite Pharma. I apologize if I mispronounced your name. Are you on? All right. Do we have anybody on the call from Kite Pharma?
I think they have declined the public comment for today.
All right. Then we will just roll. So any questions at all for Lauren? I know 90% of that went over my head. So you did a great job distilling that down. So Noon, do you all have a proposed criteria for us to look at?
So this will be a series review. It will be the first part of the series for CAR-T therapy. The DRC will help us with another review in February. And in February and January meeting, we will present the proposed criteria for CAR-T to the board. We don't have any today.
And Lauren, I mean, in the state of Utah, we only have 2 locations where this is performed. Am I correct? LDS Hospital and Huntsman?
That's correct. Those are the only 2 certified facilities for the run.
All right. Thank you. All right. Well, why don't we move on and look at the methadone prior authorization that we so readily sent Lewis back to fix last time. Lewis, have you got your criteria?
Yes, let me present that PA criteria and share. All right. Make it a little bigger for you guys. Is that better? Can you guys see it?
That's great.
Okay, so here are the revised criteria from last time. It was recommended that we combine criteria number 1 and 3 from the other form to include the prescriber attests to the patient has an intractable pain associated with active cancer, palliative care, hospice care, or sickle cell, or that the patient is an infant discharged from the hospital with a methadone taper less than 1 year of age. Yes or no? If yes, please sign and submit. No further information required. So that was something that was asked to combine those two criterion, and so now it's into number 1. And then here, it was recommended to add gabapentinoids to number 3, as to make sure that the provider is aware that the patient is taking other combination therapy with methadone that may be problematic, or cause the patient to have more side effects with methadone. All right, and then after that, we're also adding language or clarifying language for number 8. For prescriptions greater than or equal to 50 mMe per day and or taking with dangerous combinations, can the prescriber attest that an opioid overdose reversal medication, naloxone, nalthlamine, was prescribed? That the patient was counseled and overdose prevention education was provided. So we made it change the language here to include opioid overdose reversal medication, as was recommended. And we also included, I believe it was Dr. Weinstein that wanted us to include an EKG attestation. So has the prescriber completed a baseline EKG and plans to monitor at least annually? Number 10. And then lastly, I think Sam was saying to change the language to include MOUD. So methadone used for the treatment of opioid use disorder should be administered through an opioid treatment facility and billed through the medical benefit as part of a comprehensive medications for opioid use disorder MOUD program, in contrast to just using MAT. And that is all of the modifications to this PA form that were recommended and implemented.
All right, does the committee have any questions for Louis? How does this look compared to where we were last time? I think it looks really good. Catherine?
Yeah, so I'm not sure that the intent of moving the infant criteria to an or was really met there, because really most of what is below number 1 doesn't apply to the infant. So it almost seems like infant should be separate, like a completely separate thing that doesn't require everything else to be yes, if that makes sense. Because the infant isn't over 18, the infant is not going to be in the controlled substance database, etc.
Oh, so are you saying, Dr. Smith, if the provider has the situation with an infant and they answer no, then would they be able to continue on?
Right. I mean, isn't the point that in order for this criteria to be met to get methadone, that every answer is yes? That's the idea, right?
So if this applies, right? If there is an infant discharged from the hospital on a methadone taper and they answer yes, then that's it. They don't have to go through all the questions.
Right, or very few of these questions would apply, basically.
Right, and that's that bold statement after the yes, no. If yes, please sign and submit. No further information required.
Yes, please. Okay.
If you don't mind my jumping in, I think it does what you want it to do. If it is an infant, then they need to do nothing else.
Gotcha.
I think that's structured correctly to your point.
Yep, I agree. Thank you.
Thank you.
I appreciate all the work done to refine the form, and I think it includes all of the safety features and adjustments, the flow as well as the information. I did have one question on number 3. I know we had an extended discussion about the combination of opioid agonists, and methadone specifically with other centrally acting drugs. We've got benzodiazepines, barbiturates, and gabapentinoids as drug classes. And then we have two, essentially what are muscle relaxants specified out. And I'm just wondering if that's inclusive enough if we wanted to if we just wanted to make this one minor change, combine those two into a category of perhaps something like centrally acting muscle relaxants, or what our pharmacy colleagues think is the best way to do that, because there are certainly others that might be, equally concerning. And then that makes that consistent with the other bullets. So that would be the only thing I would suggest we consider. Otherwise, I think this is ready to go. Thoughts?
Well, Louis, we're going to take a motion. If the motion passes, then you can go back and fix that one item, and we trust you'll do it. And so if there are no other comments about the form, can I get a motion?
I would move we approve the prior authorization form with this minor amendment as suggested.
Thank you, Dr. Weinstein.
Second.
Thank you, Dr. Smith. Appreciate it. All right, everyone, all in favor? Aye.
Aye.
Right. Any opposed? The ayes have it. Motion carries. And Louis, thank you for your work on adjusting the form and bringing it back to us.
Thanks, everyone.
We have hit the end of our agenda.
We do have one more prior auth to review for debut.
Oh, okay. I'm probably looking at an old agenda, huh?
Oh, it's on the second page, or maybe.
Oh, we never go to 2 pages. Okay, I've got it. This is perfect. I think in the future you should all limit to 1 page. Luis, you've got this one too, it looks like.
Yes, and I think Noon recommended that we have one public comment, and she recommended that we allow that to go first, and then I present the revised PA.
All right, Dr. Tim Benke, are you on?
Yes, hello, good morning.
Good morning. You've got 3 minutes. Brian Larson loves to be our timer, so he'll be tracking that, at least for this month. So take it away.
Great. Let me pull up my notes that I sent to you all yesterday. Basically, what I'd done is I saw the minutes from last time and just added a few comments. So essentially, if you look at the notes from last time, one of the comments is that it was recommended that the criteria be broadened to include atypical Rett syndrome that don't have the genetic marker. And I would say that we should exclude the use of debut to people who do have the genetic marker. And that genetic marker is a gene test that shows a loss of function variant in the MECP2 gene. I think otherwise there would be safety concerns for its use. The next comment was how to essentially follow patients who are taking debut in terms of understanding that it's been of therapeutic benefit for them. And one of the things that was used as part of the FDA approval is this thing called the Clinical Global Impression of Improvement. And any of the other scales, there was another scale that was mentioned called a Clinical Global Impression of Severity, and that's really not appropriate for this. That's really a research tool that was used as part of the stratification in the study. So the CGI-I is probably better, but you only want to get that after somebody's been on it for a period of time, 6 to 12 months. And the CGI-I, as the way the FDA approved it, said that if a family says, we think that this is helping, that was their threshold for approval. And I think a physician needs to somehow document that, to say, yes, this is what the family says, and we agree with that. So, and that was what basically a CGI-I of 3, which was their threshold, was basically the family saying, we see an improvement. So those are really my comments in a nutshell in terms of what was provided in the minutes last time. And I'll use any other time to answer any questions that you have. Thanks, by the way, for letting me do this. The reason why I'm here is I'm the medical director for the Rett Clinic at Children's Colorado, and I've written a number of prescriptions for people in the state of Utah with Rett syndrome who come to our clinic for care.
Thank you, Dr. Benke. Catherine, do you have a question?
Yeah, and this is just my curiosity. What is the safety concern with atypical Rett syndrome?
So people who have what may be misclassified as atypical Rett syndrome due to other genetic causes, such as a CDKL5 mutation or a FOXG1 mutation. The safety concern is that mechanistically, we know how DAYBUE works in the context of Rett syndrome. Outside of Rett syndrome, I think we don't have any safety information, and being quite cautious, I would be hesitant to prescribe it for anybody that didn't fit under that mechanistic umbrella or had otherwise been tested in a systematic way for safety.
Perfect. Thank you.
I think one of the other issues is that there's another syndrome called MECP2 duplication syndrome, where the entire MECP2 gene has been duplicated. And we also want to make sure that, as it also often happens, people will just say, oh, there's a change in MECP2, they have Rett syndrome. And MECP2 duplication is a very different syndrome. And you would want to be very careful that people are in their diagnosis.
All right. Any other thoughts? Comments, questions? I apologize, my dog's growling in the background. Louise? Oh, Dr. Brenton? And then Amanda?
I just had one question for our guest. So we have the safety concerns. Is there no then effective function then? So if someone has if they don't have the gene documented Rett syndrome, the medicine doesn't help either. Is that right?
It just hasn't been tested either for safety or efficacy.
Okay, thank you.
Is there another hand raised? I think Amanda Champ and Jennifer Britton.
I'm sorry,
All right.
I couldn't get off mute. Could you hear me now?
Yes.
Yes.
I got an email from Nan. I submitted previously to provide public comment. You guys heard from me last time as well, but since the criteria had been shared, I just wanted to provide a few additional comments, if that's okay.
Noon and Brian, since we don't have this on the agenda, what are the rules?
Amanda, I think if you have provided the public comment from the last time, if you would like to provide an additional public comment, we will need a COI from you.
And yeah, I submitted that previously. Like I submitted it again.
If you want to resubmitting that after the meetings, I think that would be fine. We limit them to 3 minutes still.
All right.
And I did submit an additional COI after the last meeting before this meeting, so you should have that.
I can take a look again. Thank you.
All right, Amanda. We'll turn 3 minutes over to you.
Right. Thank you. My name is Vaney Champ, and I'm a managed care pharmacist in medical affairs at Acadia. And I really appreciate the opportunity to provide you with some additional information on DAYBUE and Rett syndrome that's relevant to the criteria under consideration. With regard to CGII and CGIS, Acadia asked that Utah Medicaid not require either of them for the coverage of DAYBUE. CGII and CGIS are clinical trial tools that are not routinely used in practice. With CGII, a clinician assesses whether a patient has improved or worsened after initiating treatment. And with CGIS, a clinician rates the severity of illness at the time of assessment, but this measure is relative to the clinician's own experience with other patients that have the same diagnosis. Therefore, using either CGII or CGIS would not be an appropriate requirement as a condition for coverage or the continuation of coverage of DAYBUE for Rett syndrome patients. Physician attestation can confirm an improvement or lack of worsening of signs and symptoms of Rett syndrome from baseline over time, instead of tools such as CGII, which again are primarily reserved for use in clinical trials. Acadia also asked that Utah Medicaid modify coverage restrictions related to the type of Rett syndrome a patient has. As discussed previously, Rett syndrome is diagnosed via clinical evaluation of the patient's symptoms. In the draft criteria, number 4, all 4 main diagnostic criteria are required for approval. And having that requirement limits the use of DAYBUE to only typical or classic Rett syndrome patients. Atypical Rett syndrome patients have many similar symptoms as typical Rett syndrome patients, but they do not have to have all 4 main diagnostic criteria for diagnosis. To be diagnosed with atypical Rett syndrome, patients must have 2 of the 4 main diagnostic criteria, plus they have to have at least 5 of 11 supportive criteria, which I can share those with you later in the interest of time. And the draft criteria as it stands would not allow atypical Rett syndrome patients to be approved for DAYBUE, despite its indication in this population. And these atypical Rett syndrome patients are different than the concerns that Dr. Binky had. You know, they would not be the CDKL5 patients, or they would not be those patients that he described, just to clarify. And I also wanted to reiterate that Rett syndrome is a rare disorder. It might be difficult for patients to access a Rett syndrome center of excellence or specialist. And many Rett patients rely on multiple providers, including primary care physicians and pediatricians, to manage their comorbidities and provide the best care for them. So thank you so much for letting me talk again today. I really appreciate your time.
Thank you. We appreciate that. Does the committee have any questions? All right, I do have one question, Dr. Benke. Is this a drug for primary care, or is this something that can be followed by primary care after having been seen by someone very familiar with Rett syndrome?
I think it depends on the primary care provider. I think that there are many primary care providers that are capable of doing this. You know, I think that medicine is a team sport, and I hope that there would be a partnership, and there are many people that are available to help them. But I think people in rural communities have special relationships with their primary care providers, and it could be done completely at the local level if need be. If there are barriers to care, there are many ways to get around that. And so I would support primary care providers being able to prescribe this. We have many examples of where families go to primary care physicians and say, I think my kid has Rett syndrome. They get the primary care physician provider to do the test, and then they probably will get them to prescribe the DAYBUE as well. And they can easily reach out to us. I talk to many people over email and the phone about trying to help them with this. And I think that I would suggest that primary care providers can prescribe this. And by the way, I agree with what Amanda Champ just said about those other issues. They were in my comment too.
All right, Luis, why don't we turn it over to you to take a look at the form?
Thank you, Eric. So yes, this is the revised form. And so as you can see, the criteria tries to align with any recent guidelines, which are mainly, for Rett syndrome. As I know, these are expert consensus statements that I've looked at to kind of guide me and guide the team, the Medicaid pharmacy team, through this PA. So with number 2, does the patient have a diagnosis of Rett syndrome confirmed by genetic testing with mutations in the MECP2 gene? And so I believe that's a reasonable criterion because of the things that Dr. Benke has stated with, concerns for safety in those that do not have that mutation, and also those who may have other mutations. And per the consensus guidelines on managing Rett syndrome across the lifespan, 2020 July, it was published in the BMG Pediatrics. They do also make a recommendation to do gene testing for this condition as part of the diagnostic criteria. In addition to having diagnostic criteria, as you see number 4, does the patient meet all of the following diagnostic criteria for Rett syndrome with a period of regression followed by a period of recovery or stabilization? So this is also, we believe, our team believes that this is also a reasonable thing to include as part of PA criteria because the majority of those with Rett syndrome have, atypical diagnosis. And last time we said that, if there is an atypical presentation and the provider has adequate documentation, we can consider approving debut. It's not that we're just strictly going to stick with typical, right? But since the majority of the cases are going to be typical, we just want to make sure that proper diagnosis is there, because as Dr. Benke mentioned, there are other things like the MECP2 duplication syndrome and other neurodevelopmental disorders that the patient could also be diagnosed with. And so this is just thinking about patient safety mainly. And so, yes, Dr. Benke.
Really sorry to interrupt. I
No
would
problem.
I want to make sure that I wasn't misunderstood. I don't think that criteria 4 is needed. If you have a loss of MECP2 function with the genetic test, that is sufficient to qualify you for use for debut. I think meeting criteria 4 is really going to be a challenge for especially primary care physicians. It's often this is a really academic sort of distinction between atypical and typical Rett with the MECP2 mutation. And you might have 3 Rett specialists that give you 5 opinions on that. So I think that 4 is going to make things a challenge for families to have access to this, because it may require them to be seen by a Rett specialist to make this distinction.
Okay, because I've also read that. Thank you for that comment, Dr. Benke, and by all means, thank you for contributing, and I appreciate you being here, because I'm no expert on Rett syndrome, but I did read something about with in some cases there are MECP2 mutations presenting in a patient that doesn't have the Rett symptoms, and so that's also something that I would bring up, but I don't know what you think about that.
Yeah. So and I have. Oh, sorry.
No, go ahead, Dr. Benke.
So mechanistically, it's the genetic loss that qualifies somebody for therapy, and it's you will still be symptomatic with it, and having access to the medication is likely to result in some form of improvement. So I'm not sure I understand what your question is.
Luis, were these criteria in the clinical trials?
I'm sorry, what was that?
This question number 4, was any of this information required in the clinical trials?
Yes, I'll let Amanda answer that one. I believe that the answer is yes, though.
Yeah, in the clinical trial, it was only included classic or typical Rett syndrome patients just to get a more homogeneous patient population to try to show that the drug was in fact the reason for the results that were seen. But it is FDA approved for both atypical and typical Rett syndrome patients. And I just wanted to kind of follow up on what Dr. Binky said. If you have number 2 saying does the patient have a diagnosis of Rett syndrome confirmed by genetic testing with mutations in the MECP2 gene, you would have already checked the box for number 4, because a patient will not get a Rett syndrome diagnosis without having like those clinical symptoms, and they would get a typical diagnosis if they check the box for every single one of those in number 4, or an atypical diagnosis if they had 2 of those 4, plus again 5 of those 11 supportive criteria that I referred to in my comment previously. So I think to his point, if a patient satisfies number 2, they should qualify for DAYBUE.
All right, thank you. We appreciate Acadia making the comments they have. At least, quite frankly, I'm comfortable with number 4, and I think it may not be something that needs to be continued, but my thought process would be let's run with it for 6 months, see how it is, come back and look at some data. But I'll let you continue through the criteria.
Thank you, Eric. I appreciate it. And so number 3, I wanted to go back and just clarify that number 3, medications being prescribed by or in consultation with a provider specializing in the treatment of Rett syndrome. And so, as Dr. Benke mentioned, he gets calls from different PCPs for consultation. So we would require some kind of documentation that happened in order for this to be approved. Number 5, does the patient have a clinical global impression scale severity, a score of greater or equal to 4? So again, Dr. Benke has clarified that this scale for the CGIS is mainly used in clinical trials. Although I don't think that it is unreasonable to include to require some kind of scale where we compare, the patient's status for their condition before treatment and then after treatment. And I don't think it is unreasonable, but I'll leave it up to the board to decide what we want to do here or to recommend.
Again, I like the fact that there's an objective metric. There's lots of situations where new drugs have come to market and we've been told, well, that's only used in clinical trials, but as medicine evolves and as clinicians look for some of those objective measures, practice changes, and things that may have been clinical trial tools soon become part of clinical practice. And so I think you making an assessment as clinicians at the state of Utah, and I don't think it's wrong to require that. Now, it could be that they don't do the test, but they submit additional information or provide chart notes with documentation. But at that point, the clinicians at Utah Medicaid can then, are having these reviewed by a clinician. Is the fact that clinicians have clinical judgment, and so I think you allow the clinicians to exercise that clinical judgment they've been given. So you're looking for appropriate information from the physician, and that can take many forms. But quite frankly, personally, that's my view on that.
I agree. And we can, if we see that it is becoming a barrier to treatment in the future, then we can always modify the PA. But I think it is important to require, what's their status now versus after.
Great, thank you. Dr. Smith?
Yeah, I don't think there's really enough patients with this disease that we can really say to come back in 6 months, or let's just see how this goes. I think it's reasonable to require that they have the positive genetic test and the diagnosis. I don't think 4 and 5 are necessary. I think those should be stricken from this, and that we should keep it simple and, you know, in consultation with a Rett specialist is really providing a lot of what we're intending.
Dr. Britton. Britton, you had your hand up. If you're talking, you're on mute. All right. Everybody can hear
There we
me.
go. Okay, I think I figured out how to. Sorry, it was this different screen now. All of a sudden on Google Meet. Can you guys hear me now?
Yeah, we got you now.
Okay. All right. Dr. Smith, are you? I would love to second your motion if you're okay to make that a motion.
I would.
So we have a motion and a second that we remove 4 and 5 and approve the criteria with the other items.
Yes.
Okay, and Louise, I think, you know, you and I are sitting in a different camp. But I don't know. It's unreasonable where we are. And, you know, I would ask that, you know, yourself and the clinicians as part of the board come back. You know, after we've worked through a few of these, and if you're seeing something different in actual practice, then we'll want to revisit this and have another discussion. So, and maybe even, you know, that's something that you just schedule a quick follow-up for next May or June, after you've had a small period of time. I think to Dr. Brennan's point, or Dr. Smith's point, we're not looking at a ton of patients, but we are looking at something that could have a major impact on Medicaid. So we'll just leave that at that. So we do have a motion and a second. All in favor, say aye.
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 Aye. I'm guessing Dr. Brennan's saying aye since it was her motion, or she seconded it. So we'll go with that. And any other comments? All right, we'll move ahead with this. Louise, thank you. A lot of work understanding a very difficult subject. So we appreciate the research and effort and energy you've done along with the University of Utah. So
No, thank you all. I appreciate it.
thank you, Louise. All right. With 2 minutes to spare, we are going to end this meeting and move on with our days. So this being the last meeting of the year, I will say farewell and thank you to all of you. Wishing all of you a wonderful holiday season, and hope everyone gets to spend time with family and friends and those people they love and want to be around. So very much appreciate everyone. And with that, do we have a motion to adjourn?
So moved.
I will second it. All in favor? Okay, we're going home. Everybody have a happy holidays. Thank you.
Happy holidays.
All right. Bye-bye, guys.